birth control strategies for treatment of female patient with venous thrombosis. The mic is yours.
Thank you, Professor Ayman, for this lovely presentation. I'm honored and very pleased to be here with you today. So my presentation will be about contraception in women with a history of venous thromboembolism, clinical considerations. I will talk about venous thromboembolism. I will refer to it as VTE just to be easier and more simple to follow me along. So whether you're managing an anticoagulant treatment in a hospitalized patient, or you're placing IUDs in your clinic, or you're just simply doing a routine counseling in the primary care facilities, everyone encounters this issue, and this issue has consequences. So irrespective of our specialties, we have to be in theme with what's going on with the new guidelines regarding this aspect. So first and foremost, we have to separate the hormonal options from the non-hormonal options. And speaking of non-hormonal contraceptive options, here matter is very simple and easy. If we talk about tubal ligation or sterilization, yes, it is irreversible, is a permanent solution. So the decision has to be made very thoroughly, and it should be taken into account for long life-term consequences, but is an effective method for women who need it or even choose it at the end. Barrier method, they're safe concerning VTE, but as you see, they are not as effective as other options. Copper IUD. Copper IUD is very common, it's popular, and in most cases is very well tolerated by most female patients. So non-hormonal contraceptive options, all of them are safe and good to use for women with history or risk of VTE. The complexity comes when we talk about hormonal contraceptive options. Now, again, we have to distinguish between combined hormonal contraception, and this, I mean, estrogen with progestin containment and the progestin only options. So when you talk about a woman with a history of VTE or a patient with a high risk of VTE, I think everyone knows that estrogens are contraindicated because they increase the risk of clotting. So, well, logical, you would think, okay, then progestin only is the answer. Well, yes and no, because the clotting risk, yes, it's dependable first on the presence of estrogens, secondly, on the dose of estrogens, but not only. It also depends on the type of progestin. So as you see now, we are here in a fourth generation of progestins with drospirenone. And interestingly enough, the risk of VTE increases with the generation. In first generation, not used so much anymore. Second generation, levonorgestrel, which is very commonly used in IUDs and with no additional VTE risk or minimal VTE risk. Third generation progestins, a little bit higher risk, and drospirenone is not advisable because studies have found that the COC or the combined oral contraceptives which contain drospirenone are linked to significant increase of risk in VTE. So we have to take all of this into account. And when we take all of this into account, we reach these first line options. So progestin only IUDs, no additional risk of VTE. Progestin only pills, microdosed progestin only pills, again, no additional VTE risk. But when we reach subdermal implant, for example, Nexplanon, which is very commonly used and popular, unfortunately, we have less data. And the medroxyprogesterone acetate or the progestin injections, which are done every 3 months, are not recommended because although they're very effective in contraceptive effect and use, they were studied regarding the VTE risk, and it was shown that they do indeed increase VTE risk, so they're not indicated. Now, what to avoid? Of course, we have to avoid combined hormonal methods, the ones which contain both estrogen and progestins. And when we talk about combined, I'm not referring only to oral contraceptive. I'm referring also to the transdermal patch and to the vaginal ring, because contrary to common belief that they bypass the liver and it's not the first stop, there are several studies who demonstrated that even the vaginal ring and transdermal patches do increase the VTE risk, and the transdermal patch, it increases it even a little more. Emergency pills are not commonly used, they're not routinely used as a contraceptive. Of course, you have to eliminate a possibility of a pregnancy before using them, but if you have a woman with a risk of VTE in need, you can prescribe them because they're not at a risk of increasing VET. So you can use them as an emergency contraception option. Special consideration, if a woman is current VTE on anticoagulant, no hormonal contraceptive option, only after she's stabilized. Postpartum, only after 6 weeks, not before that. In breastfeeding women, after 6 weeks, and avoid estrogen because it can affect the milk supply. So if you can remain with contraception after a clot, no estrogen, no problem, almost, as if I showed you. Thank you. Shukran.
Thank you, Mervat.
I
Very nice talk.
picked quick, but I'm open to questions if there are. some.
At the end.
Sure.
Thank you, Mervat.
Thank you.